So welcome everyone. As we start, I would like to take a moment to acknowledge the traditional and ongoing custodians on the lands that we join here today. Where I put my feet on the ground, that's the Whadjuk people of the Noongar Nation. And I would like to express my respect to the elders past, present and into the future. And to acknowledge the commitment and as somebody who's relatively new to Australia, how much of a privilege it has been in my life to have the opportunity to learn and be part of a nation that has such a proud and enduring connection to country. And at Health Consumers Council, we acknowledge that this always was and always will be Aboriginal land. And we look forward to moving together with Aboriginal people and non-Aboriginal people towards reconciliation. So as I said in the introduction, we will be hearing today from two speakers. We'll be hearing from Professor Grant Waterer and from Selena West. And they will introduce their backgrounds and give you an overview of give you a couple of perspectives, an overview of what it means now as we are in Western Australia living with COVID. So I will now invite Grant Waterer. Grant is a professor at the East Metro Health Head of Medicine, sorry Grant if I get all this wrong, but you've got quite a job title. Head of Medicine, Medical Services at East Metro Health Service and the Royal Perth and Bentley Group. And you have kindly made time in your diary today to give us a bit of an overview of the reality of living with COVID here in Western Australia at the moment. Grant.
Thank you. Can you see my slides?
We can.
Okay, so thanks for the kind introduction. Yeah, I'm a respiratory physician by trade and academic whose interest is lung infections, and I'm the Director of Clinical Services for Royal Perth and East Metro. I'm just going to relatively quickly cover what most of my patients and their loved ones and their carers are asking me, and some of the things that the Health Consumers Council asked me to cover. So just so we're all on the same page, what is COVID-19? It's an infection from a virus, and viruses are very tiny organisms that are designed to do not much other than just reproduce themselves. And they can only reproduce themselves by using other hosts' machinery to do that. They're not actually able to reproduce themselves. So their only way of survival is to infect other organisms and propagate. So COVID-19 is a disease due to a virus called SARS-CoV variant 2. It's very, very similar to other coronaviruses that are one of the major causes of the common cold. Anyone who's been alive longer than 5 or 6 years has had multiple coronavirus infections in their life. It's not genetically engineered, that's very clear. It's a natural virus. And viruses are designed to mutate and adapt. They do that all the time. Every time they replicate, they mutate, and they're always looking for ways to gain advantages over other viruses in our ecosystem. And if you just think back at 20 years, we've had SARS-1, we've had Middle East respiratory syndrome, we've had influenza pandemics, obviously it was the 1918, but we had the 2009 swine flu epidemic from Mexico. This is not the first virus pandemic, and it certainly won't be the last. What SARS-CoV-2 does is it gets into our body either by inhaling it, which is the main route, or by ingesting it. So if someone coughs and there's some particles and you touch it, we all touch our face often, it will get into your mouth. And it attacks the lining of the sinuses and the throat. So that's why coronaviruses cause cold-like symptoms. It also gets into the lining of the stomach and the intestines when we swallow saliva and snot and all those things that are happening. And that's why it can cause things like, vomiting and diarrhea. If our immune system doesn't control it, however, it then starts to do some nasty things, and it can attack the lining of the blood vessels, causing clots and heart attacks and strokes. It attacks the lining of the lung, causing pneumonia, and it can cause the immune system to kind of overcompensate and start to cause all kinds of lung damage. And that's been a major driver of all the intensive care use around the world. I'm often asked, why do we keep getting new mutations? And that's because if you look at where the virus is spreading around the world at the moment, there's more SARS-CoV-2 virus replicating than any other virus in the history of the world ever. And every time a virus replicates, and every time it goes from one cell and releases and goes to another, there's a chance it will mutate. So the sheer chance of mutations is enormous, and there will be millions of new mutations occurring every day. Most of those will be nonsensical and not helpful, but every now and then the virus gets lucky and it gets an advantage. So we've had this kind of race of the viruses, and the original strain of COVID-19 is way back in the crowd now. Obviously Delta came to the fore for a bit. Then we got the first variant of Omicron and now the second variant of Omicron. And there will be others. And the virus is basically racing other various versions of the virus to see who can be the most infective and consume the most hosts, because that's how it propagates. If we think about how infective it is, there's a number that many of you have heard called the R0 number, and that means for every person who gets infected, how many other people will they infect? And any R0 above 1 means that a virus is increasing. So the original strain of COVID had an R0 of about 2.5. So for every person infected, about 2.5 people would get infected. The Delta, it was 5 to 8. For Omicron, it was 10 to 12. And the most infective virus we know of, measles, is about 15 to 18. So there's still some way to go. Equally, the virus is now being acted on by immunity from prior infection and from vaccination. So the mutations that favour escape from those defences will be favoured over other ones. There's no advantage really for a virus to become more virulent, to kill more people. There's no advantage for them to kill the host. So in general, viruses actually tend to become less virulent over time as they pass from host to host to host. But when you're having lots of mutations, there's always the risk that you're going to get a more nasty one. How safe are you if you're triple vaccinated? So this is data from Queensland that was published in January, at the end of January. And I'll just focus on a few numbers here. So if you look at a 70-year-old or older male, if they're not vaccinated, their risk of death is 362 out of 10,000, or about 3.6%. If you're triple vaccinated, that risk is 18 in 10,000, or about 0.18%. So you're 20 times more likely to die if you're not vaccinated, or the other way to look at that is that you're 20 less times likely to die if you're triple vaccinated at 70 compared to if you're not. And that relative risk is even better at some other age groups. If you're female and over 70, in actual fact, you're more than almost 30 times more protected from death by being vaccinated than triple E vaccinated than not. So triple vaccination gives you an enormously high protection from death from COVID-19. So you can see here that, for example, at around 60 to 69, 1.4 is only 0.014% risk of death. So not zero, but a very, very low risk of death and a very significant reduction compared to unvaccinated people. In terms of protecting you against hospitalisation, this is British data, only just published. You can see here that after 2 doses of vaccine, pretty good protection against hospitalisation with Delta. But with Omicron, it was declining over time. So if you were getting out to 4 to 5 to 6 months after being double vaccinated, your protection against hospitalisation was dropping to about 30%. So that was the reason for the booster. And you can see here whether you're boosted with Pfizer or Moderna, you get pretty good protection, 70 to 80% protection against hospitalisation, having had a booster for Omicron, and for Delta, pretty close to 100. And Delta is more, causes more severe infections than Omicron. So that's very helpful that you get very high levels of protection. And in terms of what about just getting sick? Well, what you can see is that double vaccination was getting to around 60% against just getting symptoms. For Delta, much lower for Omicron. And again, pretty much the same trend here, that triple vaccination gives you very high levels of protection for Delta, modest levels of protection for Omicron against just getting symptoms. What does all that mean? It means that vaccination is highly effective, apart from symptoms from Omicron, where I would say it's effective rather than highly effective. But for nasty things like death, triple vaccination is incredibly effective. Against hospitalisation, very effective, and for symptoms, modestly effective. So given that decline that I also showed here, more boosters are inevitable. And in fact, for people at very high risk, the Australian government's just recommended a second booster, so a total of 4 vaccines. Is there anything that puts you especially at risk? There's no doubt that age is the overwhelming one, and there's a really significant increase after 70 years of age, and that keeps going up and up and up, 80 and 90. People who are very obese, so body mass index above 40. Diabetes does put you at about a 10 to 15% greater risk, but that's significantly reduced by vaccination. So a triple vaccinated diabetic is probably only 3 to 4% more times at risk than an unvaccinated than a non-diabetic who's been triple vaccinated. Underlying heart disease, again, increases the risk by 10 to 20%. Again, that increased risk is significantly reduced by being triple vaccinated. If you need dialysis, if you have chronic liver failure, those both increase the risk again by 10 to 15%. Chronic lung disease itself only very slightly increases the risk, and for asthma, probably not at all. COVID-19 can cause asthma exacerbations, but asthmatics don't seem to be at much higher risk of hospitalisation or death, which is reassuring. The main risk group is people who have what we call severe compromise to their immune system. So those with AIDS, who've had organ transplants, bone marrow transplants, those having active chemotherapy for cancer. And because all those things really reduce your ability to respond to a vaccine. So these are people who are at the highest risk. What can you do if you have those risk factors? Keep up to date with recommendations on extra boosters, like has just been recommended. Have your health as well controlled as possible. So the better controlled your diabetes is, the better controlled your heart failure is, the better controlled your emphysema is, the better you'll do. I will talk in a minute very briefly about there are some extra early treatments for people at very high risk, and having a conversation with your GP about whether you're one of those people who might benefit. And obviously do what you can do to reduce your risk of exposure. So be sensible about big gatherings, particularly while there's a lot of COVID in the community. And I'll come back to this a number of times. Washing your hands regularly and wearing a mask are important. What can you expect if you get COVID? Many triple vaccinated people will be asymptomatic, even those who are elderly. Possibly up to 50% of all the COVID infections we see in the community or more will be people who never realised that they actually had it. If you do get infected, upper respiratory tract symptoms, so basically like a bad cold, plus or minus loss of smell. And with some of the early variants of COVID, this was much more common, but now with Omicron, the loss of smell is only in about a quarter of people or less. Increasing respiratory distress can occur, again, much less common in people who are triple vaccinated. And that's picked up by increases in your breathing rate, drops in your oxygen in your blood. Your doctor may hear crackles. But for you, it's going to be noticing that you're short of breath. Gastrointestinal symptoms and even abdominal pain are quite common, particularly with Omicron. Diarrhea, vomiting, nausea, dehydration. The things to watch out for is if you're having those things and you get dizzy when you stand up, or you notice you stop passing urine in the last 12 to 18 hours, those are danger signs that suggest that you're getting over dehydrated. A very severe headache can occur with COVID, as can chest pain. You should never ignore any chest pain, but lots of people are presenting to emergency departments and are being sent home, but that's perfectly okay. That's what we're there for. And there are a lot of many more symptoms in unvaccinated people because disease tends to be much more severe. What's different about Omicron is that it is more infective than Delta. but it does seem to cause less severe disease. And whereas in Delta and the earlier variants, we were mostly talking about a respiratory disease where people were dying of lung failure, with Omicron, more than half the presentations tend to be with nausea, vomiting, diarrhea, and less so with respiratory. And that's even more so in the vaccinated people, that it tends to very much be the cold symptoms and the gastro symptoms rather than a lung disease. Are there any effective treatments? There are a few that you may read about, called things like sotrovimab, molnupiravir, nirmatrelvir. All of these drugs are effective in some degree in reducing the risk of going to hospital in unvaccinated people. None of these drugs have any data in people who've been vaccinated. And that's really important, because the amount of effect these drugs have is vastly less than the effect that vaccination has. So they're not a substitute for vaccination. And indeed, in the one that has been looked at in people who are vaccinated, it had no effect. So these are not magic drugs. I don't think that they will produce large amounts of benefit and may not produce any benefit at all in people who have been vaccinated. And so we're really limiting it into people who have severe immune problems, who may not respond properly to vaccine, and therefore we're giving this to ameliorate the risks that they suffer because they're not responding to vaccine as well as the rest of us. Lagevrio or molnupiravir is being used in residential care homes, but again, it's I just want to stress that there really is no evidence that these drugs add anything in people who have been vaccinated. What should you do if you get COVID? Obviously, be fully vaccinated. Keep your boosters up to date as advised by government. If you do so, you've optimised your chances of having very mild disease. Wear a mask when you're out and about. Wash your hands regularly. Don't eat and drink without having washed your hands. As soon as you come home, wash your hands. Really important. Those measures do cut down your risk of getting COVID by as much as 50%. And more importantly, one of the key things about how sick you get is how much of the virus you get on the first hit. So the COVID is a race between your immune system and the virus, and the bigger the dose of virus you get to start, the bigger the advantage the virus has. So things that you can do that limit the amount of initial exposure you get will give your immune system a hand. So a mask and washing hands is really important. Obviously staying away from those who are infected if possible. Avoid big gatherings, but certainly while there's a lot of community COVID around. And then I'd suggest preparing for getting COVID yourself. With Omicron, because of the amount of vomiting and diarrhea that people have had, having some kind of fluid or salt replacement, the gastrolytes, the Powerades, that kind of thing at home. Knowing in advance if you're someone who might benefit from the preventative therapies by having talked to your GP and knowing how to escalate if you do get COVID. Do you know how you're going to get essential foodstuffs if you're having to isolate? Do you know how you're going to isolate from others in the household, or is that even practical or possible? Have you thought about bathrooms and bedrooms and how it's all going to work? And how you're not going to get bored isolating, making sure that you're going to have access to TV or an iPad or something, because it can be really boring isolating. If you get COVID, you need to register for the home monitoring service to see if you are in a high-risk group that need more close attention. So the monitoring service works by logging in to the website. It runs you through some questions, and those people who are at highest risk will be offered more close monitoring by the service. And that's something that you can initiate yourself. What does the next few years have in store for us? Well, typically in a pandemic, it comes out of the normal winter season. And then each winter season, we tend to get lesser and lesser bumps. So it wouldn't surprise me if we're seeing a surge now. It wouldn't surprise me if in our normal peak flu season of, or late July, August, September, that we saw another bit of a bump this year. So it might come down and then go back up a little bit, not as high as initially. And then next winter, it's going to be there, and the winter after that. And in actual fact, swine flu that we had in 2009, every second or third year, it's the main cause of flu every winter. So we're going to be seeing COVID-19 in whatever variant is the most common every year for, the next decade or more. Beyond that, so beyond next year, a lot depends on what mutations come up. And as I just said, the swine flu that we had a decade ago is still with us. So a lot depends on whether there are more mutations, which I think is very likely, whether there are mutations that escape our existing vaccines, which frankly is also likely, and so newer vaccines are likely to be needed, whether they're nastier than Omicron. I think that's unlikely, but it's possible. And then how long does the vaccine boosters actually work for? And the reality is it's probably going to be less than 12 months or around the 12-month mark. And so annual boosters, at least, are probably with us for some time. And then finally, because lots of people ask me about long COVID, and this is a real thing. It's people who particularly have had more severe COVID, finding that 4 to 6 months later, they still are having problems with fatigue, lack of exercise tolerance, memory problems, all kinds of issues regarding headaches and weird and symptoms can occur. The frequency varies from 1 to 20% of the series you look at. It's clearly much, much less in people who are vaccinated than are unvaccinated. If you have to go to the intensive care, you're much, much more likely to get long COVID than if you're just hospitalised. And if you're hospitalised, you're much, 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 much more likely to get long COVID than if you just have symptoms. So that clearly the more severe disease you have, the more likely you are to get long COVID. It doesn't seem to be particularly influenced by age or chronic conditions, other than the older you are and the more chronic conditions you have, the more likely you are to end up in ICU. But if you get any of these things after COVID, then obviously see your GP because you may need further assessment. So I'm going to finish up there, and I'm going to see if there are any questions. I'll see if I can.
Grant, thank you very much. That was both very informative, really clear, and really helpful, covering a very wide range of information. But yes, that cartoon is very apt, I have to say, when trying to incorporate all of the information that we have coming at us about COVID. So you've done a great job, I think, of really making that very clear. We have had a couple of questions you mentioned there, and I wonder too if you might want to, unless you're planning to share something else, we can.
You can. I'm trying to figure out how to stop sharing my screen, or
okay,
you can take it away.
No problem. Yeah. So there should be a little. I'm just going to pause this a sec. So Grant, you mentioned there about the boosters, and there's been a couple of questions about boosters. I know particularly in the health consumer community that there would have been a few people who were really early adopters, and so will have had their kind of full swathe of injections earlier. Is there any news on the timing of when this, for the general population, the 4th booster will come out?
So ATAGI, which is the Australian Therapeutic Advisory Group for Immunisation, is the kind of chief scientific panel, and they look at all the data and advise government of when to do that. Last week, they advised to move to the 4th booster for people who have severe immunocompromise. I think we're waiting to see the data coming out of other countries like the UK, like Israel, around how effective, how long are the boosters waiting. And I think there's also obviously considerations around where does government focus at the moment. So, it's trying to make sure that everybody gets a 3rd one before it puts its efforts into going for a 4th one. It would be my guess that if you look at the data that's out there, I would suspect somewhere between 6 and 9 months after the 3rd dose is when we're all going to require another booster. And there's also a little bit of waiting to see that. So all the companies are at the moment trying to modify their vaccines to be better against Delta and Omicron. And obviously, if you're going to have a booster today, but next month there might be one available that's better for Omicron and Delta, do you wait a month and lots of science in balancing that up. But I would expect that we'll see advice in the next couple of months that probably, around mid-year, I'm expecting people to be advised that they probably have another booster. But we'll see how the data goes.
Yeah. Thank you. You also mentioned, so there's a couple of other medications that you mentioned. One was the early treatments that so far we've got data on for people, the effectiveness in people who are unvaccinated. Could you just expand just a little bit more about how people might access those? So obviously you mentioned about get in touch with your GP, see if you're in these categories. There was a question that was submitted in advance. If people, for example, may not have a regular relationship with the GP, how else might they find out or get themselves onto that pathway?
So the website that you log on to that I gave you for the home monitoring service, it will ask a series of questions. And if you flag as someone who might be eligible, that then sends an alert through to the relevant area health authority so that they can then follow up with you about getting access to that. And then finally, of course, if you are unwell, you can always access through a GP, but we are, or ED, but we are encouraging people to go through the website.
Thank you.
And most people who are highly eligible probably have a regular specialist as well. And so again, talking to your specialist who can also help hook you up that way.
Great, thank you. I know too that I had seen an article, I think, that referred to a new drug, which was a preventive drug being made available, particularly from my lay understanding, for people who are in that severely immunocompromised category for whom the vaccination may not afford very much protection. Is there anything that's that you can share about that?
So those are the three agents that we have in Australia is Preventive, which is it's an infusion, it's an intravenous injection of an antibody that attacks COVID, if you like, and tries to stop it from being in your blood. The other two agents, the molnupiravir and the Paxlovid, are antiviral tablets, a bit like Tamiflu for influenza. All three of them have studies in unvaccinated people that if you take the drug early enough, within about 3 or 4 days of symptoms, that there tends to be less hospitalizations. The effect of each of them is a little different, but all in slightly different populations. So comparing them head to head is a little difficult. But only one of the three drugs has any data available on vaccinated people, and it gave no benefit. That was molnupiravir, and it gave no benefit in vaccinated people. So we don't have really any evidence that they have a big effect in vaccinated people, which is why I think the focus is on get vaccinated, get vaccinated, get vaccinated. And in those who might not get the same response to vaccination, to use these drugs there as a kind of additional belt and braces approach.
Thank you. Just one final thing on those medications. Are those medications that have been around for a while and being used for other things?
No, they're all new. So they've all been developed specifically for COVID, although with the exception of sotrovimab that was very specifically developed for COVID, the other ones have been sort of around in pharmaceutical companies for a while as antivirals for other indications. And have simply been found to be useful against COVID in the laboratory, and so then progressed to clinical trials.
Great, thank you. We've got another question in that someone has mentioned that they're looking at the clinical protocol for antivirals, and it seems that unvaccinated is a risk factor that perhaps sits above other risk factors. But in category 1, there are a few types of people who are immunocompromised, but not the majority. Would you have any comment on the access to drugs for people who are unvaccinated over people who have done what they can to get protected, but may or not be getting the same effect from the treatment, about whether or not how you prioritize access to this very limited pool of drugs?
Yeah, so I understand the question, which I guess is a very difficult ethico-moral political one, isn't it? We as doctors would not discriminate against people once they have an illness on the basis of choices they've made. So they have a very clear priority list. At the moment, there's not really a risk that for the list of indications that we have, there's not really a risk that we would run out. What I would stress is that if you've chosen to be unvaccinated and you end up getting one of these agents because of that, you're still nowhere near as protected as you would have been if you've got vaccinated. Okay, these are not substitutes for vaccination. You know, they're less than half as effective as vaccination, and probably more like a third or a quarter as effective. So I would absolutely not be wanting people to take away a message of I don't need to be vaccinated now because these drugs are available. They are not as remotely as effective as vaccination.
Great, thanks, that's very clear. Now, this might be a question, I'm not quite sure if it's within your scope, so please do feel free to say that if it's not. With access to rapid antigen tests, or the RATs, as we are, you know, everybody's in search of them, could you comment on whether or not how effective RATs are, depending on how symptomatic you are? For example, is it worth doing a RAT if you've not got symptoms, but you're perhaps being exposed? Given that they're in short supply for some of us, we're thinking about making sure that we use them in the most effective way.
Yep. So RATs are about 90% effective overall. And that loss of 10% is usually in early disease. And it's to do with how much virus you have floating around, you know, in your saliva and in your nose. And so it's not unusual that a RAT could be negative and a PCR test would be positive, because a PCR test is much more sensitive. Typically though, your RAT will become positive over the next day or two. So if you're asymptomatic, I would probably not do a RAT test unless it was required for me to go to work. So, you know, someone who's working with the elderly, working with at-risk people, or, you know, if you really, you know, want to know, should I be going and seeing mum or dad because there's someone else in the house that's infected and I don't want to spread it to them, you know, and I don't want to line up at a COVID queue and wait several hours. A RAT test is a reasonable, you know, compromise. Once you're symptomatic, RAT tests are more like 95, 96% sensitive. And so, you know, certainly they have much higher utility once you're symptomatic.
Thank you. And you mentioned before about some of the symptoms that people should be looking out, as well as upper respiratory tract, that people might experience some gastro symptoms. Is that the same with regards to that symptomatic and the RAT use? So are they still...
So people who get vomiting and diarrhea will have, as far as we know, have the same positivity from RAT testing of saliva. It's just how your body's choosing to manifest its symptoms, I guess. And, you know, one of the things about vaccination is very good at getting antibodies into your blood and preventing severe disease. It's not as great at getting antibodies into your nose and your gut, which is that's a different antibody. You need IgA, whereas you need IgG in the blood. So that's why vaccines don't seem to be quite as good at preventing symptoms, but are really good at preventing severe disease.
That's really clear, thank you. We've had a few questions from people who perhaps might be quite vulnerable themselves, but do still have people who might be coming into the home, say for example, support workers or other healthcare workers. Are there any, what might you say to someone who is, like I say, needing to have people coming into their home, isn't always able to control if that person, where that person has been in other aspects of their life? So just some practical things people can do in the home environment to make that interaction as safe as possible. So
I think that unless you're going to live in a plastic bubble, over the next 2 years, there's a 70 to 80% chance you're going to get COVID, all right? It's going to be an inevitable part of being part of the human race, given how infective it is and how widespread it is. So what you're really trying to do is limit your getting a very large amount of COVID as your initial exposure, particularly if you're at risk. So, you know, you're going to want to make sure that you're vaccinated. Then if someone comes into the house and has symptoms, probably you're going to say, not today. I think it's reasonable to ask people to have a mask, and you to wear a mask while they're around. And then obviously, you know, we're all humans and civils, but you offer them a drink or a cup of tea or whatever. You want to make sure that all those things are cleaned after they go and not sitting around. You probably want to, just wipe over the surfaces, particularly if they've been coughing or, something like that. Other than that, I think, you're not going to be able to prevent yourself from getting COVID. It's more about just making sure that you're not getting a big exposure and doing all those simple things.
Thank you.
I just quickly saw that text come up. It is certainly natural immunity from COVID seems to also only last 6-9 months or so and then weans off. And that's a factor with all coronaviruses, as it is with influenza, that our immunity isn't permanent. So it is possible to get the same strain twice, yes.
Right, thank you. And just going back then, I've been reading again in the popular media about Omicron, about this question, obviously back in 2020, it was covered, don't touch a surface that's been touched by another person, and this is how long the virus lasts on particular surfaces. And from what I've been reading, like I say, in the popular media, I see that perhaps there's more focus now on the airborne contribution of the virus spreading. We did have a question about, for example, if at home, using something like Glen 20 in the air, does that make any difference? And I know that other people have spoken about, opening doors and windows and ensuring good ventilation. What else could people be doing with regards to that airflow? And is this question of surfaces versus airborne, like what's the current knowledge about that?
So I think if you've got someone in the household who has COVID, then airflow is important because there's going to be constant release into the atmosphere. For casual, contact, someone just coming in and going out, airflow, I mean, certainly spraying lots of disinfectant around the air is not going to do anything. Right. The virus in general, will be in the air transiently. That's when you'll inhale it and then it'll settle onto a surface. It's very clear that you can get it through both inhaled and ingested. So, you need protection from both. Again, I think initially when COVID came out, we were trying to stop everybody from getting COVID. Mm-hmm. And where we've moved to as a world is, that's almost impossible. So what we need to do is make sure people are as well protected as possible. And so that's why vaccination is important. And again, it's why, just making sure you don't get a huge dose to start with. You're doing everything you can to limit that. Those are the things that you can do to still have some control. Yeah.
You mentioned before, and you gave us that kind of look ahead at the next few years. And obviously there will be people in the community who will always perhaps be at heightened risk. Can you comment on whether or not there's anything, if you like, about almost when you might be, if we've got a 70 to 80% chance of getting COVID, if someone is in a very vulnerable situation, they are got this much higher risk. Is there any advice for them in terms of how to, for example, if you're very high risk, do you avoid getting it at the peak, in particular when there may be more demand on hospitals, or for example, if there's a limited supply of medications? Or I mean, it's a bit of a difficult question, but if you're assessing your own risk as somebody who is, likely at higher risk of severe complications if they do contract COVID, is there any advice you could give people?
I don't think that there's ever going to be a good time to choose. I don't think our healthcare system is going to completely collapse with this surge that we get, and then we'll go back to business as usual. COVID is going to become part of our normal spectrum of diseases we have. While I said that 70 to 80% are going to get it, that still means that 20, 30% are not. So again, I don't think COVID's any different to influenza or any of the other viruses that wander around every year. So respiratory syncytial virus that is a frequent cause of significant problems in people with chronic lung disease and chronic heart disease. Viruses kill people all the time. We just don't realize it. And so just doing, again, the basic things: wash your hands regularly, using a mask, asking people who are clearly infected with something to not come into your house. That I know that's particularly tough for some people who have to provide care to grandkids. That is a real issue. And that's, again, all you can do is look at how do you limit your exposure to people who have an obvious active infection. That's probably the best you can do.
That's been really helpful, and your information's been really clear. I've just spotted one question that we didn't ask you. Do you know anything about people being able to access PCR testing from home if, for example, they are at a heightened risk and are concerned about going into the community?
I'm sorry, I don't. It might be a question to direct to PathWest or SHIC and see whether that is a possibility. I'm not aware of anything myself.
No problem. Well, Grant, I would just like to say a huge thank you. You have not only addressed way more than the questions that we received, but also handled all the questions that have come up since. So I hope everyone will join me in the usual Zoom way. Obviously, if you feel free to stay with us, but I do know you have another appointment. But if everyone can stay with, join us in the normal Zoom way, which is, to say a huge thank you. I know that you're a very busy person, particularly at this time, and it was really very good of you to make the time available to provide information that we're seeing some comments in the chats about, very informative and very well presented. So thank you very much for your time and for sharing your knowledge.
Thank you. Happy to do it and happy to come back anytime.